Okay, now let's talk about a few movement disorders, and we've kind of grouped them all together here. The first one we'll talk about is hemiballismus, which is caused by a lesion in the subthalamic nucleus, which leads to loss of inhibition of the thalamus by the inhibitory pathway. These patients usually will present with unilateral wild-flinging movements that are contralateral to the side of the lesion. Hemiballismus can be often very severe, and when it is, it prevents daily activities. The first method of treatment usually involves anti-dopaminergic drugs. Now, I don't know if you guys are familiar with this dance trend, the new dance trend called the Harlem Shake, not the old one from like the hip-hop 90s, the new Harlem Shake. If you take a look at those videos, that dancing motion, that is what hemiballismus reminds me of. So I use that to think about hemiballismus. It actually also leads quite nicely into our next movement disorder, which is chorea. Now, chorea is Greek for dancing, and that's actually describing what these movements look like. They are dance-like motions, and when you see chorea, you should think of a basal ganglia lesion. Now, chorea is one of the defining features of a disorder. Which disorder is it? The answer is Huntington. Next, we want to discuss athetosis, which is sometimes described as snake-like movements, meaning that it is slow and writhing. It is also suggestive of a basal ganglia lesion. In what disease would you expect to see this? Again, you could see this in Huntington disease due to the damage of the caudate that is a part of the basal ganglia. One feature that can often distinguish it from other similar movement disorders is that it can be seen in the fingers as the convoluting, writhing movement of the fingers. Myoclonus is a sudden, brief, involuntary muscle contraction. You can also think of it as sort of a hiccup. You can also get this type of contraction in myoclonic seizures. The cause of myoclonus is not well understood, and although it is usually benign, it can be a symptom of a variety of diseases. Dystonia is a sustained, involuntary muscle contraction. This is something like writer's cramp or torticollis. It can be hereditary, but can also result from a variety of causes, including the use of neuroleptics. There is no cure available, and there is no standard treatment. Treatment, however, is aimed at reducing symptoms and is usually arrived at through some trial and error method. There are very good examples of all of these disorders on YouTube. You should really take a look at them and really get a sense for what the differences between these are. And don't forget to check out some of those Harlem Shake videos. Okay, now let's talk about tremors. Tremor is a rhythmic, oscillating movement of agonist and antagonist muscles, and there are three types. An essential tremor, which is the most common type. It is most prominent when the patient's limb is held in a specific position and disappears at rest. The tremor increases with stress and decreases with alcohol and beta blockers. Let's watch a video of this movement.
Okay, Gene, can you hold your hands out in front of me? Spread your fingers apart.
Okay, so I hope you could appreciate the tremor in her left hand especially. And of course, what this person would need in that situation is alcohol. So the second type of tremor is a resting tremor, and that is worse at rest and disappears with movement. Now, Parkinson disease, as we've already discussed, is characterized by a special type of resting tremor called the pill-rolling tremor. Let's take a look at that here. Lastly, we'll talk about intention tremor. This is brought about by tasks like the finger-to-nose task or the heel-shin task. And do you remember what these tasks are testing again? What part of the brain? The cerebellum is involved in making these coordinated movements. But with an intention tremor, these patients cannot move their limbs in a straight trajectory and frequently overshoot or undershoot their target. An intention tremor can be seen in a number of neurological disorders. However, it is often mentioned in the context of a specific neuroautoimmune disease. Do you remember which one? That would be multiple sclerosis. Now remember that multiple sclerosis is a type 4 autoimmune disease, and we'll mention that a little bit later. However, while we are on the topic, are type 4 autoimmune diseases antibody or cell mediated? They are cell mediated. And that, folks, is called integration. Now that we've thought about the role of dopamine signaling in the basal ganglia, let's consider Parkinson's disease. Now, Parkinson is caused by the loss of dopaminergic neurons in the substantia nigra, and it is a bradykinetic movement disorder. For step 1, this is a classic type of pathology picture where you would be expected to look at the midbrain, which is what we're looking at here. This is the midbrain, and you should be able to recognize that there's diminished substantia nigra pigment and that this patient has Parkinson's. For comparison, the midbrain on the left is for someone who does not have Parkinson, and you can see the darkly staining substantia nigra there. And then obviously here you see a lack of staining, which is indicative of Parkinson's disease. So let's watch a video of a patient with Parkinson's disease. Now you should be able to recognize in this video this pill rolling tremor, which is a real hallmark of Parkinson's disease. Here's another video that I want you to take a look at.
Let's see you walk a little bit for me. Okay. Just turn around and walk towards me. Okay, turn around. Okay, turn quickly. And turn quick. And quick turn. Good. Okay. Okay, that's good. Just walk back a little bit. Back, walk towards the dot there.
Same way.
Just normally, just walk normally. Turn. And come back. And turn. Good.
Okay, so what I hope you were able to gather from that very long video is a few things. The first is that you should be able to notice the patient has a stooped posture. And one really random thing that I do to help me remember this is I picture a bent P. So that's the first thing, the stoop posture. The second thing is the Parkinsonian gait. It is notable for the slow initiation, but once the patient is able to start walking, he can speed up and even find it hard to stop. When patients turn, they also take more steps than others would to complete that turn. You should be very familiar with how these two clinical presentations look, as they will often be given as part of a question that requires you to deduce that the diagnosis is Parkinson. The mnemonic we've provided for Parkinson is TRAP, which stands for tremor, cogwheel rigidity, akinesia, and postural instability. The diagnosis is made clinically. However, the classic finding on autopsy is depigmentation of the substantia nigra. That's what I showed you earlier. But under the microscope, what you might also see are Lewy bodies. You can see those pictured here where the arrows are. Now, do you remember what Lewy bodies are made of? Lewy bodies are composed of alpha-synuclein inclusions. Now, before we move on, let's think about the pathophysiology for a second to see if there's an intuitive way to understand this thing. The major problem in Parkinson is thought to be a lack of dopamine from the substantia nigra. Now, as we discussed, dopamine from the substantia nigra acts on the basal ganglia to facilitate motion, and it does that through activating the direct pathway while inhibiting the indirect pathway. So it makes sense that a lack of dopamine would result in problems initiating movement, since dopamine acting on this system serves to facilitate movement. Huntington disease is a hyperkinetic movement disorder. It is an autosomal dominant trinucleotide repeat disorder, meaning that offspring will have a 50% chance of inheriting the gene regardless of gender. Symptoms are caused by lesions in the striatum, specifically the caudate nucleus. The neuronal death in the caudate is due to NMDA receptor binding and subsequent glutamate toxicity. Symptoms include chorea, aggression, depression, and dementia. On brain imaging, diminished caudate nuclei leads to dilation of the lateral ventricles. Here we see a normal coronal section of the brain. You will notice the striatum here. Now let's take a look at a coronal section from a patient with Huntington. You can clearly see a difference, I hope. The caudate is greatly reduced, leading to an expansion of the lateral ventricles. When you see a pathology picture like this, if the lateral ventricles look abnormally large, you should definitely be thinking about Huntington. On a genetic level, the problem arises due to CAG repeats. These are inserted into the Huntington gene. With each generation, the number of CAG expands. This causes further destabilization and earlier onset of the disease. This is a process known as what? I left you in anticipation, and that's the name of the process. While we are talking about Huntington's and its trinucleotide repeats, are there any other diseases you can think of that are also caused by trinucleotide repeats? Well, there are quite a few actually. So we have Fragile X, which has CGG repeats, myotonic dystrophy, which has CTG repeats, and Friedreich's ataxia, which has GAA repeats. It is important when you are studying this material to always look for unifying themes and mechanisms. This is the type of thinking that is critical for success on the boards. Alright, you guys know what time it is. It's time for a flash quiz. Now, how does dopamine affect the direct pathway and the indirect pathway? Dopamine from the substantia nigra acts on the basal ganglia to activate the direct pathway and inhibit the indirect pathway. And overall, this will lead to a facilitation of movement.